let's say we've progressed and you've given FLOT and the patient now has recurrence of disease. And I'm going to ask you the same question you asked us before we started, and now it's on you.
Okay.
So let's say the patient relapses within 6 months. What are you going to do at that point? At all assuming HER2 negative.
Okay. So if they relapse within 6 months, we would normally deem this patient actually failed the neoadjuvant stroke adjuvant chemotherapy. So these are people who essentially are moving on to what we would normally deem as second-line chemotherapy for advanced disease. Except the problem now is you used up all the active drugs. So you used up your taxane, you use your platinum, you use your fluorouracil. So in this situation, I think the other agent that is that we would normally turn to is probably irinotecan, which is also an active agent that has been shown in a Japanese Western Japan oncology group trial to be similar to weekly paclitaxel, and also the much smaller German AIO study that showed it to improve overall survival, as well as the Korean study. So irinotecan certainly is an active agent here. So I think that is something that we would consider using. I suppose the difficulty is, of course, another active agent in second line we would normally think about is ramucirumab. But ramucirumab, the trial is either done on its own, ramucirumab on its own, or ramucirumab with paclitaxel. So the question, I suppose, is, if you're going to choose between, if you're going to give irinotecan versus ramucirumab on its own, okay, which one would you use? Because, you could potentially use either. You probably prefer to use it both, but there is no prospective data reported yet, as far as I understand, in gastric cancer. Obviously, ramucirumab is a regimen used in colorectal cancer, but in gastric cancer, there's no data available with combining the two. So, I suppose at this stage you want to know what the status of the patient is. Obviously, irinotecan is associated with more cytotoxic drug side effects. You're going to get more diarrhea. You're going to get more neutropenic sepsis. And other GI toxicity like nausea, vomiting. Whereas we know ramucirumab in the REGARD study on its own have very, very few side effects. In fact, the side effect profile is very similar to just placebo. So certainly in terms of tolerability, it's similar, okay? And the median survival, of course, these are cross-trial comparison, is similar. But the other thing you can also think about is, well, if people fail docetaxel, doesn't mean they fail paclitaxel. So can you reuse that regimen of paclitaxel plus ramucirumab? Do you think there's a true synergy between the two, and then you really should, when we think about, you really should go back and use a taxane with a ramucirumab? And I think on that matter, I'm really quite interested to hear the other panel members and see what they think.
It's awesome. It's a data-free zone. So it's what you feel in your gut, no pun intended. Yeah? Manish?
Right. Unburdened by data.
Unburdened by data, yeah.
So I think that you have to do, 5 irinotecan or FOLFIRI. I think that if you have recurrence within 6 months or maybe even within a year after doing a FLOT regimen in the perioperative setting, you have to go to another cytotoxic. You make a good point about ramucirumab, but if you're recurring within a year, you probably have very aggressive biology, and I'm not sure that same data would apply as monotherapy ramucirumab, at least personally. So I would probably do a FOLFIRI type regimen.